Hello, I'm Adam Giragosian. I'm here to present my capstone presentation for my Evidence-Based Practice 2 class for my Bachelor's of Science in Nursing degree. I'm here to prevent pressure ulcer prevention. I have a peacock question which describes a setting and a problem where research is comparing current protocol with new research and the effect rates. So in the critical care hospital setting, how does the implementation of 5-layer silicone dressings compared to current protocol before the use of foam dressings affect the rates of pressure ulcers during the month of hospitalization? So I want to see if applying prophylactic 5-layer dressings to bony prominences during the critical care setting of hospitalization is going to decrease the rate of pressure injury. Why? Because this is going to reduce further complication of injury. It's going to reduce pain, increase functional ability for our patient, decrease patient expenses, and decrease hospital cost while decreasing hospital stays. Decreasing hospital costs is important because pressure injuries cost the hospitals a lot of money because they acquire the patient's expenses once an injury is acquired in the hospital. On the bottom here I have a single descriptive study, level 4 evidence, from my article that I was researching that did the studies of the 5-layer dressings on the patients. And the studies have shown that using the new 5-layer silicone pads on all bony surfaces during hospital stay decreases the prevalence to 0. We are having an incidence and occurrence of pressure injuries on our patients while they are having hospital stays in the critical care setting. If we have a correct policy and standard for procedures, there shouldn't be a prevalence of pressure injuries. So we have to figure out new ways to handle these problems, and one of them could be a 5-layer silicone dressing. So the studies have shown a prevalence of being 0 so far while using the dressing in the critical care setting. In our policy at my hospital, we do a head-to-toe assessment upon every shift, and in that assessment we do a skin assessment. In our electronic medical record, it identifies certain areas. Usually the Braden scale is used, and we identify any areas such as open wounds or high-risk areas of skin breakdown. This alerts a wound care consult. They come in, make a plan, and nurses begin implementation of that plan. We document and communicate what we did to the interdisciplinary team so that the whole team can be on the same plan and the same page for the patient. The skin assessment includes, like I said, the Braden skin assessment on the EMR. This is going to identify areas like mobility, moisture, nutrition and hydration. All of these accumulate to friction and shear, which increase prevalence of skin breakdown. These are our real current EMR protocols that we do to identify our high-risk patient. We have to look at the possibility that it isn't possible to assess compliance in nursing and care, but in my single experimental randomized controlled trial with a level 2 evidence, they stated that it was impossible to assess compliance. And if we can't assess compliance, then we have to go above and beyond prophylactic measurement and implementation. So I feel these 5-layer dressings are going to decrease pressure injury whether or not nurses are doing their job. If we can put these dressings on our patients and comply to that, at the very least we can try to decrease these prevalences along with all the other implementations of protocol and standards. So the inclusion for these 5-layer dressings prophylactically in this research was including criteria in a wide range of problems, and we're seeing patients live longer and have multiple comorbidities. They're staying in the hospital for much longer, especially in the critical care setting. You have a patient who is sedated, even at 35 years old. They're having malnutrition, they can have major trauma, they can be on vasopressors and all kinds of stuff, and these increase prevalence of skin breakdown. Prophylactically, if we were to put these dressings on the bony prominences, we can decrease the prevalence. So this was the criteria for those dressings, all of those criteria here, not just the Braden scale of alerting the wound care consult or implementation of certain practice that we can do, like turning the patient, getting wedges, offloading, not just that, but all of these included are for this criteria. So now I want to talk about grading. I know this is kind of here and there with a lot of people. It's really hard to gather education on two-dimensional learning. My mentor told me that two-dimensional learning for skin assessment is a big barrier for learning. It really takes experience, time, and hands-on learning to really understand what the skin is doing and what stage it's in. But I have looked at the criteria and have found ways to pick apart these stages and actually really categorize them into what they need to be. So there are 5 stages, and there's also a stage of unstageable and deep tissue injury, which is where we're going to start in our grading criteria. There's going to be a quiz at the end of this for my class that is here today, and one of the questions will be on deep tissue injury, another one will be on unstageable injury, and also 5 questions on the 5 stages. So we're going to go over those stages right now, and I'm going to help you identify which stage we're in when you're looking at the skin. So the first one is a deep tissue injury. We're going to look at our skin and we're going to assess it, and we're going to notice something that's persistent and non-blanchable deep red. When you push on the skin, non-blanchable means that when you push and release, that the skin changes from a darker color to a lighter color. So there's a change in the color. So it's non-blanching. So there shouldn't be a change in the color. When you see the wound or the injury, it will be a purplish tint, dark red, maroon tint. You're going to push on it and it'll stay the same color throughout. There's not going to be any change in the color. It's going to be intact or non-intact skin, and it's going to be in a localized area. It could be a blood-filled blister, but a lot of the times it's going to be that really dark red maroon color and base, and when you push on it, it's not going to blanch. So it's persistent, non-blanchable, deep red, maroon, or purple discoloration, like a bruise. The next one is stage 1. This is the only stage of the 5 that is intact skin. Your skin is intact, but the problem is that it's non-blanching erythema, which is redness of the skin. So imagine that blister, but it's going to be red in color. It's going to be intact skin, and when you press on your skin, like if you were to press on your leg during a sunburn, you pushed on it, it would be white where your thumb was released the pressure. So this is non-blanching. It's not going to change in color from white to red. It's going to stay that redness throughout right here. Okay? It's going to be intact skin with a localized red or non-blanching redness. I can't say this enough. That's stage 1. Presence of blanchable erythema or changes in sensation, temperature, or firmness may precede visual changes. Okay. Stage 2, pressure injury, partial thickness skin loss with exposed dermis. So we're going to have, it's going to be like someone shaved off the top layer of your skin. It's a partial thickness skin loss. That is the main word that you're going to want to remember for the definition. But what the description of it is going to be a visible pink, red, moist bed. It's going to be throughout. Here you see the all red base, but you still have the wound edges. And the big thing about discerning 1 from 2 is that now the skin is broken. So in stage 1 you have redness but the skin is intact. In stage 2, top layer comes off. Now you have an open area of skin which is nice and red and meaty. Okay, it's moist. It can it can be dry in other spots. Skin has layers, so it can have different effects. Of dry a little bit here, moist there. But you're gonna mostly have a nice red base, red or pink wound base. It can also be an intact or ruptured serum-filled blister. These blisters, they fill up with this serum and they can rupture. Just because the skin is over top, that doesn't mean all of it's intact. It's a broken area of skin, and there's going to be a nice red wound base underneath that. Sometimes that will be unstageable. But the difference between a stage 2 and stage 3 is the fact that stage 2 is fat is not visible and deep tissues are not visible. So you have that really just top layer of tissue there. Granulation tissue, slough, and eschar are not present. Again, granulation tissue, slough, eschar are not present. That is the dark scabbing of the skin, and it's the wet moistness of the skin that's kind of like pulling off, like muck and mud. That's the difference between 2 and 3. So stage 3 is a full thickness skin loss. That's the definition of stage 3. The characteristics of it is which adipose fat is visible. So remember, in stage 2 there is no fat visible. That's that's that yellowy, real wet looking tissue in there. The slough and eschar may be visible. You're gonna have that. You can maybe have that moisture, or you may have that dryness. The depth of the damage can vary. It might have undermining and tunneling, but the areas we're gonna focus on the characteristics of the fact that certain things are not exposed. So what is not exposed in stage 3 but is in stage 4 is the fascia, the muscle, tendon, ligament, cartilage, and bone. So any of those kinds of characteristics in the wound will not be stage 3. What you're looking for in the stage 3 is really that depth of that loss in skin. You're looking for fat and granulation. But you're not going to see bone. You're not going to see tendon. You're not going to see ligament. You're not going to get that deep, and that's really hard to distinguish between stage 2 and stage 3 and stage 4. This is really where they get mixed up a lot. So we're going to just really look at the fact that it's not really all red and pink in base and color. There's going to be yellow, that slough, that wetness, but there's not going to be any bone, ligament, or tendons. So moving on to stage 4, it's full thickness skin loss and tissue loss. That's the definition for it. And as you see, sometimes these images are really gruesome. It's even worse to see them in real time, and especially on patients. You see a lot of these patients in the front view, but when they take off the covers and turn around, this is what you see, and it can be really disturbing sometimes. But these people need to be treated, and we need to take care of them because this is an injury that could have been prevented. And these are very debilitating and are very fatal to our patients. As you see, there's a lot of depth in this wound. There's a lot of tunneling and undermining. You have lots of coloration in there, all different colors. I'm going to say colors because what you're seeing on the picture is 2-dimensional compared to 3-dimensional, which is really the best way to see these and being able to characterize the stages. But for teaching purposes and for what I can do here without patients, this is the best I can do showing the depth. You're going to have fat, you're going to have tendon, you're going to have muscle, you're going to have ligament, you're going to see all of that. And if you see any of those characteristics, it's going to be stage 4. That's the difference between 3 and 4. The 3, you're only going to see that fat, and you're not going to get the tendon, the muscle, and the bone. So again, full thickness skin and tissue loss with exposed or directly palpable fascia, muscle, tendon, ligament, cartilage, or bone in the ulcer. Slough and or eschar may be visible, and rolled edges, undermining, and tunneling often occur. So now on to an unstageable. Most of the time this is a 3 and 4. It's like like I said, if a blister was to break and you had that skin over top of it, you can't really see what's underneath it. This is in that same kind of case, but in the case where you have a full thickness skin loss, where it's open, broken, and we can see, but there's layers of skin on top on one side of the wound or another, which is covering the actual base or how far it tunnels. If slough or eschar is removed, a stage 3 or stage 4 pressure injury is usually revealed, but we won't know because of the fact that we have that skin. So that's what unstageable is. You know that there's a skin breakdown, you know that there's going to be depth, but we can't tell how far it goes. That's when we have an unstageable wound. So here's an accumulation of all the pictures, kind of going over it again. An unstageable really covered by yellow, tan, gray, green, or brown, and that's that slough that's covering a lot of that wound. I wanted to re-emphasize that. When you have all those different layers of skin, you can't understand. So being able to pick out the characteristics of the stage, remembering 1 is just the blanchable skin, skin is intact. 2 is broken skin and it's red and wound base. 3, it's open and broken, it's got full thickness skin loss, and you see the fat, but you're not seeing the bone, tendon, and muscles. Stage 4, you are seeing bone, tendon, muscles, and ligaments, and you have full thickness skin loss. So those are the 4 stages, and that's how you're really going to compare the characteristics of the 2 to what you're seeing and to what you're putting down on paper, so that you can get the full plan for your patient. So in my evidence level 2, and in my single experimental randomized controlled trial, one of the articles that I used for my research, it says, with all the staff education, comprehension, proactive, collaborative, preventative program based on staff education and a focus on adherence to protocol for patient care can be an effective way to reduce the incidence of hospital-acquired pressure ulcers in the ICU. So we have to have a comprehensive staff education, collaborative preventative program, and it's saying we need to focus on staff adherence, because if we can get all the nurses to implement everything that we have for our patients,